Again, good morning and good afternoon. I'm so pleased to welcome you all to today's webinar, U.S. State Abortion Bans, Medical Exceptions, Human Rights Impacts. My name is Rebecca Reingold, and I am an Associate Director at the O'Neill Institute for National and Global Health Law, which is housed at Georgetown University Law Center. For those who do not know the Institute, we see national and global health law as a frontier for collaborative, international, and rights-based approaches to health and well-being for all, and our work responds to the need for innovative solutions to the most pressing global health concerns. Today, we are so pleased to be partnering with Physicians for Human Rights, Ipas, Physicians for Reproductive Health, and Georgetown University's Global Health Institute to bring you this webinar. Thank you to everyone at PHR, Ipas, PRH, and GHI, as well as my colleagues here at the O'Neill Institute for all of their contributions. And thank you to you all for your participation in what we hope will be a rich conversation. Before turning to our distinguished experts, I want to take a brief moment to provide some context for the focus of this webinar. Currently, 14 states in the US have laws in place that ban nearly all abortions. These bans can contain exceptions, including those that permit abortions to prevent the death or preserve the health of the pregnant person. However, medical exceptions frequently rely on language that is confusing or unclear, making it extremely difficult for physicians to determine whether patients experiencing medical emergencies qualify. As a result, these medical exceptions, or lack thereof, are the basis of numerous lawsuits before courts in the US. Next week, the Supreme Court will hear oral arguments in 2 cases involving Idaho's abortion law, which bans all abortions with narrow exceptions for preventing the death of the pregnant individual, ectopic pregnancy, or pregnancies resulting from rape or incest. In 2022, the US Department of Justice challenged Idaho's abortion ban, arguing that it directly conflicts with the Federal Emergency Medical Treatment and Active Labor Act, also known as EMTALA. EMTALA requires hospitals that receive federal Medicare funds to comply with certain screening and stabilization requirements. While pregnancy emergencies are rare, under some circumstances, an abortion may be needed to stabilize a patient. The Supreme Court is now poised to weigh in on whether EMTALA preempts state abortion bans to the extent that those bans conflict with the federal statute's stabilization requirement. Today, we will hear experts discuss what exactly is at stake in the Idaho cases. They will explain how these medical exceptions, or lack thereof, violate well-established international human rights principles and medical ethical obligations. They will share what it is like for physicians to practice medicine in contexts where medical exceptions to broad abortion bans do not exist or are extremely narrow, confusing, or unclear. They will lift up the experiences of other countries, reflecting on how international standards might be relied upon in the US to challenge broad abortion bans and narrow medical exceptions, and promote the human rights of both physicians and the patients they treat. Today, we will be hearing from 4 incredible experts, and I'll introduce them briefly before we hand things over to them. Dr. Tlaleng Mofokeng, aka Dr. T, was appointed the United Nations Special Rapporteur on the right of everyone to the enjoyment of the highest attainable standard of physical and mental health by the Human Rights Council in 2020. She is an adjunct professor of law at Georgetown University, a distinguished lecturer at the O'Neill Institute, and co-chair of the O'Neill-Lancet Commission on Racism, Structural Discrimination, and Global Health. She holds a medical degree from the University of KwaZulu-Natal and a postgraduate certificate in health economics and policy from the London School of Economics. She has expertise in global health equity, sexual and reproductive health rights, safe and legal abortion, comprehensive sexuality education, sex work decriminalization, and advocacy training for health professionals. She is a globally renowned and inspiring visionary advocate and thought leader of her generation. We also have Payal Shah, who is the director of the Program on Sexual Violence in Conflict Zones at Physicians for Human Rights. She is a human rights lawyer with more than 15 years of experience conceptualizing and leading capacity building, coalition development, strategic litigation, fact-finding, and human rights advocacy to advance gender equality and sexual and reproductive health and rights. She's a fellow with the University of Toronto Faculty of Law's International Program on Reproductive and Sexual Health Law and a graduate of Columbia Law School. She has published extensively on gender health and human rights in Asia and globally. We also have Dr. Michael Belmonte, an obstetrician and gynecologist and complex family planning subspecialist. He currently serves as the Darney Landy Fellow at the American College of Obstetricians and Gynecologists, an assistant professor of obstetrics and gynecology at Penn State University, and a fellow at Physicians for Reproductive Health. He earned his medical degree from the University of Illinois Chicago and completed his residency in obstetrics and gynecology at Indiana University and complex family planning fellowship training at the University of Colorado. His clinical and research interests are focused on medical education, ethics and communication, health equity, intimate partner violence, and comprehensive reproductive health care. Last but certainly not least, we have Dr. Guillermo Ortiz, who is the senior medical advisor at Ipas. He is an obstetrician gynecologist from El Salvador, having previously served as head of the obstetric department at the Hospital Nacional de Maternidad in El Salvador. He has served as a professor at the School of Medicine and chief resident in gynecology and obstetrics at the Universidad de El Salvador. He earned his medical degree with a specialization in high-risk obstetrics from the Universidad de El Salvador and King Drew Medical Center, California, and a master's in hospital management also from the Universidad de El Salvador. He currently serves on the board of directors of CLACAI, the Latin American Consortium against unsafe abortion. So a quick note before I hand things over to our first speaker, I just want to note that we are aiming to have some time for our speakers to respond to questions posed by participants at the end of the webinar. So please start to share your questions using the Q&A function as we move forward. So first, moving to Dr. T. It is well established in international human rights law that abortion must be decriminalized and that states must take positive measures to guarantee abortion where the life and health of the pregnant woman or girl is at risk. Can you tell us about the international human rights standards that underpin abortion decriminalization and broad life and health exceptions to abortion bans? And also, how would you characterize from a human rights perspective the current state of reproductive health care in US states with increasing criminalization and extremely narrow and ill-defined medical exceptions?
Thank you very much, Rebecca. And I, of course, want to start by saying that I am an abortion provider. That is my daily job. And I currently am joining this webinar from Johannesburg, from DISA Clinic, where I am a practicing doctor. And so that for me is one thing that's important to always speak about. And I think it's part of the job of destigmatizing abortion care, but also making sure that as we speak about these issues, that we as healthcare providers ourselves are seen as more than just providers of care, but as human rights defenders, as protectors of human rights in the ways in which we practice medicine. And in this context of criminalization of medical procedures such as abortion, I think it's even more important for us as healthcare workers and providers generally to understand our role and how the practice of medicine is being attacked and criminalized, but also the power that we have as advocates for patients, but also for our own science and our own expertise to really defend the rights of all people everywhere to have dignified care and services. And so human rights and international human rights laws and standards becomes the compass, becomes the guiding tool for all of us to join together in how we can do that work. And we know that sexual and reproductive health rights, they are an integral element to the right of everyone to the enjoyment of the highest attainable standard of physical and mental health. And yet many obstacles continue to remain between individuals and the enjoyment of sexual and reproductive health. And these are interrelated, of course. They are operating at clinical care. They are also operating at the level of health systems and at the level underlying determinants of health. And we've seen how in the United States, the court has become a player, a very powerful player, and an obstacle, I'll have to say, in how sexual and reproductive health rights, and specifically abortion, is able to be realized in the United States. Now, criminal and other legal restrictions, of course, in SRHR are discriminatory in nature. They violate the right to health by restricting quality goods, services, information. They also impact the ability for facilities and for managers to actually ensure that services are sustainable. They infringe on human dignity by restricting freedoms to which everyone is entitled to under the right to health, particularly decisions around respect to decision-making and bodily integrity. And we know that criminalization often fuels stigmatization and enables further discrimination based on other grounds. So if you are a transgender person who needs an abortion, we know because of particular contexts, your experience in the medical system is often, a negative and discrimination is enabled and there's no consequences. If you are a sex worker, for example, who needs an abortion care, if you're a person who uses drugs, if you're a person who's homeless, a person in an irregular migratory status, we know that all of those elements add up and they compound the negative and disproportionate impact of these existing structural discrimination, and that the law itself, in the current way that it's articulated in the United States, in the way that it's being advanced through the courts to limit and restrict, actually is in itself a form of violence. And I've often termed and structured, this argument to the UN as well, both the General Assembly and the Human Rights Council, through the various reports that I've done, that when states fail to prevent violations on the right to health, they are actually enabling violence, and that is a kind of structural violence, and we need to start articulating them as such so that our response to them can be systemic and structured, but also understanding that it cannot be a once-off advocacy moment that will get us to where we need to get to as it is in terms of the reality of the United States right now. And yet, with all of this, we know that human rights are transformative. Human rights are indivisible, and they're also foundational to thriving societies. And so, in the context of all of this legal issues happening in the United States, how do we then understand the right to health for the US citizens as important to thriving communities in the US? And this is set out for us in the International Covenant on Economic, Social, and Cultural Rights. And it gives states, member states of the United Nations, which the United States is, a template of how to move in the right direction to ensure that they respect, they fulfill, and they promote the fundamental human right to autonomy, to equality, to physical and mental health. And the Committee on Economic, Social, and Cultural Rights, in general comment number 14, goes much further to actually define the obligations of states. Often when we talk about sexual and reproductive health rights, we talk about women, we talk about young girls, we'll talk about gender equality, we will talk about feminism, right? And people start to think we are asking for favors. They start to think we are saying we are women and we are girls and we want the world to just be better just because. These are human rights that you are entitled to. And there's a set of obligations on the part of states to make sure that they protect these rights. And for me, it's about, again, contextualizing the demands and the advocacy that we all embark on at different levels, nationally, globally, through this lens of demanding that states actually adhere to their obligations as defined in General Comment number 14. That allows us to actually hold them accountable to either, like we have in the United States, where they have not ratified the right to health. So the United States does not recognize the right to health independently as a right. And we can also analyze to what extent that actually impacts their ability of the US as a member state of the UN to then have a national plan that is actually then supported by a budget, by clinical decisions and guidelines, but also by health systems management and a legal framework that is articulated, expressed, and politically aligned to ensuring that the right to health is realized. And I think for me, one of the biggest things that I can share today is that as we think about the different ways that criminalization and the restrictions that come with abortion as it has been expressed in the US, is to think about how the key principles of human rights are affected and to start thinking ahead to what else could be. We've seen the headlines around IVF. We've seen the headlines around the limitations of some of the medication we need to be able to perform medical abortion safely. We've seen how the Supreme Court justices have hinted that, in fact, because of Roe v. Wade and that particular case, they may look at other cases around same-sex marriage, around the rights that were given by the courts, around civil rights, around contraception. So we ought to really articulate this problem as a problem, or at least as a step that the state is using the law and the court to inflict violence and to ensure, unfortunately, that the right to health is not realized. And those have direct impact on key human rights of non-discrimination, of transparency, of accountability, but also of equality, privacy. We've seen how privacy has been such a big issue in terms of how these courts and the rolling bans in the different states in the US. A lot of them are around policing online searches for abortion care. People are being harassed through their social media if they are ordering. Their pharmacists are being harassed and doctors to give up information so they can be prosecuted. So there is something there to also be said about law enforcement and how, therefore, the practice of medicine itself is being opened up to police surveilling and policing in a way that we've never seen before in abortion care. But other important principles of human rights include, of course, dignity and well-being around sexual and reproductive health rights. And I think if we can articulate the structural nature of the violation that the state enables by either acts of commission or in omission. And I think in this case, by the United States not ratifying the right to health, by omitting, by not taking that step, they are enabling this structural violence to continue. And so what would be the best way forward? What would be that act that they can commit to ensure that we get ahead? And I'm sure we will get some of those answers. And so we know that with international human rights standards, states have an obligation to refrain from the use of criminal law to punish women or girls or anyone who can be pregnant from ending a pregnancy. They are also must repeal restrictive laws and policies which put women's health at risk. And I think this is important because often when we talk about human rights, we talk about the violation. But human rights, we all have a responsibility, and states have a responsibility to prevent. And a lot of the arguments that we make often is that we want to await a case of risk, a case of someone not getting the abortion. We need to also find, I think, within our ways in which we can defend and demand this right by using the prevention argument as well, so that we don't wait for a Roe v. case to end up at the court first, and really go at the prevention, the obligation to prevent rights violation, and not wait for a violation and then want accountability. We ought to be moving and pushing states all over the world on the prevention element of it. And I think in this instance, we have a big opportunity to do that. If you think about people living in poverty, rural areas, people with disabilities, migrant people, indigenous women, people who may need post-abortion care, people belonging to ethnic minorities. There's a lot that they are already grappling with every single day. People in situations of crisis, that the prevention lens is really, really critical for us to pay attention to in terms of the right to abortion care, in that we have to prevent the delay. We have to prevent the abuse of patients by people harassing them in the streets while they're trying to get to the facility. We have to prevent the medicines not being available because now the FDA is being questioned around the safety of medicines. So the idea of prevention of violation, for me, I think is a big call to action that I wanted to share with all of you today. And Rebecca, again, I'm not looking at the time, so feel free to let me know when I'm going over my time.
I think we're getting close, Dr. T, but
okay, cool. So just to wrap up sort of my initial ideas is that, of course, we have seen, though, in the recent years, really good positive trends in several parts of the world. And I think this has to be said, that the United States is regressing. They are the ones who are the outliers. They are not setting the standards for the rest of the world to follow. In fact, the ways in which they have politicized this particular issue, the ways in which non-governmental religious conservative movements have made a concerted effort to roll back on these rights, it's actually a descent on human rights. It's a descent on international human rights and established, consensus from the United Nations. And it should be articulated as such. They are not setting the standard for any of us. They are regressing and they are polarizing, but it's important that they know that they're in the minority. But we must acknowledge that they do have a lot of money to make a lot of noise. So it does tend to seem that the all is. And when you think about the people who must defend, who must advocate for safe abortion access, it's us again, the healthcare workers. And if I must choose between doing an interview and doing an abortion, I'm going to choose doing an abortion, right? Which means my voice is missing. And yet then the vacuum is filled by all of these other voices. And so how do we then support healthcare workers to be advocating for their patients, but ultimately to give services? Because that's what we want to do. I want to be giving services. I don't want to be sitting doing interviews and fighting about this particular element of medical care. I'm a doctor who's trained in many other things, and my colleagues in orthopedic surgery, in cardiothoracic surgery, who deal with multiple traumas from drunk driving and all of those things, they don't have to sit and advocate and fight so much to do the work that they know their patients deserve in respect and dignity, provided and guided for by medical science. And I think we need to be fighting for healthcare workers to do what they are good at, is providing abortion care. And we must see this as well as an attack on the practice of medicine, and see that the voice of healthcare workers more broadly has to be amplified in how we think forward and think ahead of how to overcome this particular issue. And it is a particular context to the US in how the court is being used. But it is not a US only issue of restrictions, but there is a definite flavor to it, right? And the Committee on Eradication of Racial Discrimination, CEDAW committee, and of course myself as the Special Rapporteur on the Right to Health have made several findings on this, and those are available, and I can send them on the chat for people who are wanting to read all of those long documents. And I will end here for now. Thank you so much, Rebecca.
Thank you so much, Dr. T. And I hope we can come back and unpack some of the wonderful points that you've raised. I'd like to turn now to Payal. Physicians for Human Rights has documented the experiences of physicians operating in states with some of the most restrictive and punitive anti-abortion laws, many of which broadly criminalize abortion and contain extremely narrow medical exceptions. Payal, could you share with us some of your key findings on the human rights impacts of such bans from the research you carried out in places like Louisiana, Oklahoma, and Idaho post-Dobbs? And could you also speak to their relevance for the EMTALA cases that are currently before the Supreme Court?
Hi, Rebecca. Thank you for the question, and also to O'Neill for organizing the webinar today. It's an honor to be on this panel with so many inspiring physician voices for reproductive rights and justice. And I'm really sitting with what Dr. T just shared about the difficulty for clinicians to be able to speak out generally, globally on this issue, which is so stigmatized, but also so criminalized. And here in the US, it's absolutely something we've seen time and again. When we interview clinicians, there's a lot of fear about what can be said. If we interview clinicians and they speak, and they're sometimes able to speak anonymously, but to speak out publicly is even more challenging. So really appreciating Dr. Belmonte, who's here as well, and Dr. Ortiz, who has lived that experience. And so just to say, all of that really resonated, and it's against that backdrop, actually, that my organization, Physicians for Human Rights, had really sought to undertake in the past year, in particular, research and fact-finding work to try to understand the impact of these bans on clinicians, and to undertake research in a way that allowed clinicians to share their experiences safely, securely, but also in a way that we could understand the full pattern and depth of harm, and that we weren't waiting for, the emblematic case to emerge, but actually to understand day over day how these bans are rolling out, and what they mean for clinicians in the practice of medicine. So, as you shared, Rebecca, laws in over a dozen states in the US compel clinicians to deny patients abortion care in most circumstances, and introduce really high penalties if you violate those circumstances. And the exceptions that do exist are often called medical exceptions. But these medical exceptions, I put that in air quotes, I don't know if you can see my hands, often fail to reflect medical terminology. And in the cases of exceptions to prevent death or health harm in particular, it's very unclear to clinicians how much risk or how close to death or injury a pregnant patient may need to be for the exception to apply. Further, these laws, I'm a lawyer, so it's going to be a little wonky. They change what's called a good faith standard, where we trust clinicians to make decisions in their good faith, into a reasonable medical judgment standard. What that means in many of the states that have done this, not all, but many, is that judges and juries end up standing to judge clinicians on their decision making, which is often made in really acute medical emergencies and reflects the nuances of decades potentially of medical training and practice. So where physicians are making these decisions can be easily questioned and challenged, leading to investigation and a range of possible legal sanctions, from felony charges with long prison sentences to loss of medical license to other severe penalties. So for example, in Texas, violating the abortion ban can lead to 99 years in prison and fines of over $100,000, as well as revocation of a medical license. I mean, these are really frightening consequences. Taken together, the harsh penalization of abortion, along with these narrow and ill-defined exceptions, have raised serious questions of human rights. Our work is really aiming here at PHR to try to delve into these questions, to understand through research and documentation what the human rights impacts have been. And we've started with 3 different projects over the last year that I'll share a little bit more in depth. But just to say at a high level, the data we've collected has made clear that abortion bans are leading to delays and denials of care, but also prenatal care and miscarriage management in violation of the rights to life and health. These bans are also leading to serious and wholly preventable and foreseeable physical and mental trauma in violation of the right to freedom from torture and cruel, inhuman, and degrading treatment. In particular, abortion bans are harming historically marginalized populations, also contributing to violations of the right to non-discrimination and equality. And finally, these laws are causing violations of the right to privacy and reproductive self-determination by forcing individuals to stay pregnant against their will. Our research unequivocally illustrates that the criminalization of abortion and the unworkability of medical exceptions is leading to a human rights crisis in the US. And the data we've collected underscores why federal legislation to protect abortion, including in health emergencies as EMTALA does, but also in other circumstances, is required to comply with human rights law and prevent a deepening public health emergency. So in Oklahoma, for example, in the months following Dobbs, clinicians were really aiming to navigate the laws along with patients. And so as we have been started to embark on the period post-Dobbs, we almost within a few months of Dobbs coming out, we started to do work in Oklahoma with the Center for Reproductive Rights and Oklahoma Call for Reproductive Justice to understand what the impact was of these abortion bans. Oklahoma at that time had 4 overlapping bans. To understand what the impact was on pregnant individuals' ability to access information on available care in case of an obstetric emergency requiring an abortion. And this was building on news reports that were coming out of patients being denied care and a lot of concern coming from our partners in Oklahoma on what this meant for what patients could expect if they had an obstetric emergency and went to a hospital. So we used a simulated patient research methodology in which research assistants called hospitals to provide prenatal and peripartum care across the state of Oklahoma and asked what care could be provided if they were facing this emergency. What could they expect? What protocols and policies was the hospital using? What we found was chilling. Not one single hospital of the 34 we spoke with offering obstetric care across the state of Oklahoma was able to articulate clear, consistent policies for emergency obstetric care that supported their clinicians' ability to make decisions based solely on their clinical judgment and pregnant patients' stated preferences and needs. Further, the confusion that was caused by these laws led to hospitals giving misinformation. For example, despite exceptions in Oklahoma's abortion law in cases of risk to the life of a pregnant patient, one hospital, the caller was told, nowhere in the state of Oklahoma can you get an abortion for any reason. So these findings raise serious indications of barriers to abortion access and violations of human rights. And indeed, the week our study came out, the media covered the story of J.C. Staten, who was an Oklahoman woman who was told that she needed to be on the brink of death to receive treatment for her partial molar pregnancy, which is a life-threatening pregnancy complication, and was ultimately told to wait in the parking lot. And she ultimately was forced to travel out of state to access emergency care. So similarly, we then undertook work in Louisiana, which also had similar bans to abortion. And we were really acutely aware in that context of the need to document the fuller impacts of these laws. So from May to November 2023, PHR and our partners, CRR, RH Impact, and Lift Louisiana jointly conducted a human rights fact-finding documentation, interviewing 43 health professionals and patients, as well as 2 community-based organization focus groups in Louisiana, where abortion is banned except to save the pregnant person's life, prevent damage for life-sustaining organs, or where the fetus is deemed what the law calls medically futile. Clinicians who provide abortion care in Louisiana also face harsh legal penalties. And following Dobbs, the Attorney General, who's now the governor, sent a letter to the Medical Society threatening any clinician who provides an abortion with potential legal action. The findings contained in this report were similarly chilling. The research shows how Louisiana's bans violate federal law meant to protect patients, disregard evidence-based public health guidance, and degrade longstanding ethical standards, and worst of all, deny basic human rights. In the interviews, clinicians consistently expressed fear about legal penalties if they provided emergency care. They expressed fear about counseling patients on where to go to access legal abortion. They also said that they were afraid to comprehensively document patient conditions in medical records or even care for pregnant patients earlier in pregnancy, before 12 weeks, essentially, because the risks of miscarriage were so high that they were afraid that they would be seen to have conducted an abortion if a pregnancy loss occurred. It also caused confusion about what reproductive health-related information clinicians could provide, exacerbating mistrust in the health system and harming the patient-provider relationship. Nearly every clinician we interviewed described cases in which the abortion bans caused delays due to fear of legal risks in violation of the standard of medical care. One MFM specialist described this case, and I'll just quote. She said, she was talking about a patient who had serious cardiac implications. She said she was quite sick, and they said, no, they, meaning the other clinician, said, no, we have to maximize all management options before we could offer any sort of termination procedure. And I'm thinking, but what if she doesn't want to wait that long because she could have a heart attack and die? I don't know. At what point can you act? How many cardiac meds have to fail? Okay, you failed 10 cardiac meds, so now can we talk about it? And in that case, the patient has no voice. There is no shared decision-making, none at all. What we also found, in addition to this type of incident, is also that the bans are disproportionately impacting and harming historically marginalized communities and groups in the state. Most pregnant Louisianans already live in maternity care deserts, and what we're seeing is that this is even more is increasing as clinicians start to consider leaving the state. Ultimately, what we're finding is that these bans make it impossible. Basically the medical exceptions in Louisiana's law are unworkable in practice. So finally, we then conducted research in Idaho this year as the Supreme Court began its case in the EMTALA case, which is going to be heard next week, as you noted. And the conflict between Idaho's state abortion bans and EMTALA is the core, right, of the Supreme Court case. And what the state is saying is that there is not an inconsistency between these laws. And so we really aimed through interviews with 9 clinicians who treat patients from Idaho or in Idaho, what the impact has been. And what we found is interviewees repeatedly recounting how the state's laws have led to life-threatening pregnancy complications in patients who are denied abortion. Patients in those circumstances were forced to either wait until their conditions further deteriorated or to travel out of state. And again, I just want to share a quote from an OB-GYN in Idaho who stated, "It saddens me that we're waiting for pregnant women to become infected before we intervene. Good medicine means offering treatment when we find sickness. And in this situation, we're forced to watch a sickness until it becomes worse before we're offering the appropriate medical intervention. So I worry that a pregnant is going to become so septic that I'm not going to intervene in time to save her life." Like Louisiana, Idaho's clinicians describe profound distress over their inability to treat patients in line with their medical standards of care and medical ethics, with clinicians planning to leave or already having moved from the state. The clinicians emphasized over and again the importance of EMTALA in supporting clinicians to deliver optimal emergency medical care and providing, in the words of one Idaho physician, a sense of safety for both providers to be able to provide the standard of care and for patients to know that they are being offered the standard of care and not have information or treatment withheld because we're afraid or unsure how to act. So I'll just end with one last minute. You just give me a second, Rebecca, but just to say that on the human rights impacts, what we're really seeing is that the existing federal statutes like EMTALA put in place to protect patient access to emergency care are being nullified by these state abortion bans. A Supreme Court decision clearly establishing preemption of state bans by EMTALA is essential. We're seeing a range of different risks that Dr. T outlined really acutely, but one I just want to hone in on a little bit is travel. And what we're seeing is patients being made to travel large distances. The US is a large country and traveling quite long distances to be able to access care. I don't have time to get into it now, but the testimonies in our Idaho research also really were also from clinicians who were receiving the Idaho patients. And just to say that the stories that they shared were really heart-wrenching in terms of the impact of patients in really acute crisis being forced across state lines, particularly in cases where the pregnancy was not ever going to result in a live birth, which is a particular circumstance that the international human rights bodies have really contemplated as constituting torture and cruel, inhuman, or degrading treatment. And so I think it's really important to understand the depth of the harm that's occurring and that travel is not a solution.
Thank you so much, Payal, and thank you for lifting up the stories of what folks have been experiencing in the wake of Dobbs. I think Dr. Belmonte is going to continue on the last point that you brought up related to travel. So as an OB/GYN practicing in a state that receives patients who require abortion care from states with broad bans, could you tell us how narrow and ill-defined medical exceptions violate well-established standards of care in medicine and clinical's core ethical obligations? What are some of the risks that patients face when they're not treated in a timely manner and or are forced to travel these long distances to receive care under urgent circumstances? And why is EMTALA so important to protect patients' rights and to prevent harm?
Yeah, I think first and foremost, I want to thank kind of all of the panelists for all of their viewpoints and research and all of these things that go into this, because quite frankly, as a physician, I rely on the research, I rely on the scientific evidence to really guide my practice. And it's really challenging to be in a situation where legislation, political opinions, all of these things really are affecting the way that I can care for the patients in front of me. And so really, when we're talking about laws like Idaho's abortion ban, you're really looking at a law that, quite frankly, is written intentionally to confuse and frighten healthcare providers like myself in these emergency situations. We are stuck in that situation where we don't know if providing the medical care that we have been trained to provide will end up in a situation where we find ourselves fined, our medical license and our entire career and job are taken away from us, put in jail. And quite frankly, the work that we provide in abortion care in general is so stigmatized, and we are subjected to violence every single day in this arena that it only makes that violence more heightened and really makes it challenging to navigate that situation. When we're talking about medical exceptions in general, it's difficult because the practice of medicine cannot be distilled into a list of exceptions. Really, we have to take into account the entire patient in front of us, the context of the situation, their other medical conditions. All of these things go into how we make decisions in medicine. If it was as simple as following a simple algorithm or a list of things, then I wouldn't have had to go through my entire life training to be a physician, and then continuing to improve through my lifelong experience. And so I think ultimately what it comes down to is when we're put in these situations in a need where our medical judgment would say that medical intervention is needed, termination of pregnancy is needed to prevent life-threatening consequences, we're really forced to second guess that and bring in other people to agree with us because we fear those punishments. I think ultimately, when we're talking about abortion bans in general, it's important to recognize too that, as was said earlier, ultimately these bans are in direct violation of medical ethics. Really, you cannot take care of the patient in front of you, take into account their own life experience and their needs and wants in that situation, and really provide the best medical care if you're not taking that into account. And so I'm not a lawmaker, I'm not a politician. I find myself, unfortunately, in these spaces because my hands are tied clinically. And the only way to reverse that is to continue to speak out and fight against these things. And so really, I think the point that Payal has made is that really you're taking out your patient's experience, you're taking out that shared decision-making process that is central to everything that we do in medicine. And our duty is to respect our patient's autonomy, but that's threatened when their liberty, their agency are restricted. And so ultimately, as was said earlier, certainly the bans are unjust and discriminatory, but at the end of the day, the real consequences are that people are disabled or lose their lives because we cannot intervene. And so I think when we're talking particularly about kind of the risks that patients face when they're not treated in a timely manner, or kind of in my experience when I was practicing, particularly in Colorado, where patients were, I would say about 50% of my patient population was traveling from Texas or surrounding states. I frequently encountered situations like the ones in those reports from those states that we just mentioned, where someone is bleeding heavily, but it's not heavily enough where the physician in Texas is willing to take that risk. And so then they go to the next emergency room and they're also denied that care. And by the time they make it to me, their blood levels are at such a dangerous level where I'm concerned that they're losing blood flow to their major organs. And what will their life look like even if I intervene at this point? Will they be stuck in an intensive care unit for God knows how long? Will they need organ transplantation to reverse the effects of what has occurred? And so I think when you cannot take into account all of those nuances and you're truly just focused on, will I be second guessed because a jury who doesn't have my medical training and expertise is then going to decide if they felt like my judgment was correct. I think the other thing to keep in mind is we have probably all heard these stories of people having hemorrhages or excessive blood loss, concerns for blood pressure that are skyrocketing that could lead to a stroke, a heart attack, other things like that. We've not heard as much about some of these other stories, like when we're talking about a cesarean scar ectopic pregnancy, where a pregnancy can actually implant in someone's prior cesarean scar. And in most cases, that cannot safely grow. And so really the best prevention is intervening as early as possible and then allowing that patient to recover, and then they can have a subsequent pregnancy if that's what they want. And taking into these situations where truly we're fighting against a ticking time bomb is just not in line with how we have been trained to take care of the patient in front of us. And so when we're thinking about regulations like EMTALA, really these federal protections allow me to provide my patients with life-stabilizing treatment in those medical emergency situations. And so when we're dealing with these regulations that are directly interfering with my ability to provide that care, it muddies the water, quite frankly. And I think when we really just talk about that confusion, we lose sight of the patients that are truly being harmed. And as was said earlier, I find that unfortunately, being in reproductive healthcare in an OBGYN space, there's really no other area of medicine that has to deal with these interferences from the government, from politicians, etc. No one is saying, hey, can you make sure that the ethics board and all of your colleagues are in agreement in replacing the hip on that patient? And it's unfathomable that we are put in this situation where we truly can't provide the best care to our patients. And we truly owe it to them because they entrust their lives with us. So it's ultimately really disheartening when I find myself in a situation too where we are also subjected to, unfortunately, the vast majority of media stories that focus on well-off white women who are being forced into these difficult situations, and we're not really taking into account the people who are harmed the most by these bans. People who are in rural area, BIPOC communities, young people, trans people, people with different sexual identities. I think those are not the stories that are being uplifted, but I myself have run into all of these situations with all different types of patients. And my job now affords me the ability to travel the country and speak to physicians all over the country. And I hear these stories day in and day out. And so I think it's important that we really focus and emphasize the fact that reproductive justice is focused on allowing people the right to have a child if they'd like, to not have a child when it's not the right time for them, and ultimately to live safe and healthy lives and raise those children in safe and healthy environments. And we cannot do that in this context. Thank you.
Thank you so much, Dr. Belmonte. And thank you for raising, the disproportionate impact of these laws on already marginalized and underserved groups. I think that's something that Dr. Ortiz will pick up on as he begins to share experiences from his home country of El Salvador. So Dr. Ortiz, your home country of El Salvador has operated under an absolute abortion ban for many years now. How has that ban affected access to emergency obstetric care in El Salvador? How are local advocates using human rights arguments to advocate for the addition of exceptions to the total ban in various contexts?
First of all, thank you for the invitation. And I will take some words and some ideas and to follow the conversation of the other participants of the panel. And I want to highlight that it's not just in El Salvador. The situation is pretty similar in Honduras, Nicaragua, the Dominican Republic, and some other countries in Latin America. The law in El Salvador changed in 1998, and after the law change, at that time I was working in the hospital, and the main hospital of El Salvador for women's care, and we start seeing women coming with unsafe abortion more often than in the past. But I think what was the trigger of the worsening? It was the worst part. It was like this memorandum coming from the Ministry of Health, stating that all physicians, nurses, and health workers must report the cases, abortion cases, to authorities, even if it's just a suspicion of having an abortion. It was like a very shocking for all. I recall very well. I was the head of the emergency room at that time, seeing women coming from the rural area or even the urban area, coming handcuffed by the police to perform a medical exam for even for spontaneous abortion. Because also I want to notice that in Spanish, the word abortion is for even for spontaneous abortion. We don't have that like this difference in English, that miscarriage and abortion, to make the difference. So that is one of the reasons why abortion work is criminalized. And as soon a woman comes to a facility and the assessment shows that it's an abortion, then everybody starts thinking this is a crime. And how this situation affects the care, particularly with obstetric emergencies. In those countries, it was at that time and still happening. The home deliveries happens for different reasons, mostly for access. In one of those cases, the result of the fetus of the neonatal was about result even for the emergency situation, then a woman was criminalized and sent to jail for homicide. It was like as Dr. Belmonte said, also I think Payal stated as well, there was a confusion because the law is not clear. So which case could be considered as an abortion, which case could be considered as homicide as well. So that is why many women in El Salvador have been sent to jail, and they're paying condemns for 15 years, 55 years for committing homicide instead of having abortion. And also I want to notice that the local organization, the human rights organizations, are working to release those women from jail. And so far they have been released 75 women from jail for having obstetric emergencies. But it's just not working to release them, it's also trying to prevent to happen again. And for that, they're working to escalate those cases to Inter-American Human Rights Court, which is based in Costa Rica. So at least in El Salvador, 2 cases was sent to the Inter-American Court. One is the Manuela case. It was a poor woman living in the rural area. She had lymphoma, which is a lymphatic cancer, and she had a home delivery because it was an obstetric emergency. She also developed a preeclampsia and postpartum hemorrhage. And as soon as she arrived to the facility, she was accused. She was like although it wasn't her, because she was like even in the clinical chart stated that this, her husband was living outside the Salvador. She migrated to US. So it was like this pregnancy is like the result of infidelity. So it was after that, those clinical charts transform to a criminal charts. And you're seeing some physicians and nurses using criminal language instead using clinical language, trying to make a case to transform an emergency to a criminal case. And that was the case of Manuela. She was accused for having an abortion, and then she was handcuffed, and care was delayed until the police came. Unfortunately, Manuela died in prison, on jail, and the case was, unfortunately, was a positive resolution came from the Inter-American Court. It was 3 years ago, focusing mostly on the professional secrecy, the confidentiality, and not report those cases to authorities, and stated that physicians, nurses must do the work that they must do, and not being like a judge and trying to transform a clinical case, an emergency case, to a criminal case. But also, beside that case, another case, which is the Beatrice case, which is a very serious illness woman. In 2013, she had lupus and also an encephalic pregnancy, and she was asking for an abortion. And then the case escalated to the Supreme Court, the National Supreme Court, and the state denying the abortion to her. So the case is also in the Inter-American Court. The hearing was last year, and we're still waiting for the resolution. And it was for the very first case, an abortion case. And it was for the very first time an abortion case in the Inter-American Court. So we are expecting, hopefully, a positive resolution soon. And I think I'm going to stop here, but before that, I want to highlight something that Dr. Belmonte said, that in the next, it was not enough to ban abortion in El Salvador. The year after that, there was a new law and added to the Constitution. There was like considering the a person from the moment of conception, which changed many other things, and it was like also including ectopic pregnancies and some other cases to delay treatment and waiting to the fallopian tube to explode to transform the case to immediate care, putting women and to the age, to the high risk, and putting also the physicians on this tough decision when to act, if I need to act or not, how much is too much, how much I need to wait to act in those cases. And as a result, some women make it and some don't. So it's just the reality. And listening all the participants on the panel, I immediately transport to those countries, to Guatemala, to El Salvador, to Nicaragua, to Honduras. It's unbelievable that this is happening here. It's a really huge setback in terms of human rights and also in terms of scientific evidence information. So I'm going to wait for questions and concerns. Yeah.
Thank you so much, Dr. Ortiz. So I think we are getting some really great questions that our speakers are responding to live. I did want to come back with a follow-up question for certainly Dr. T and Payal, but Dr. Belmonte and Dr. Ortiz, if you have reflections here, I'd love to open it up to you as well. But recognizing that there are limitations associated with holding the US accountable before human rights bodies, how can clinicians and advocates in the US use human rights to change abortion laws that we're seeing here in this country? Dr. T, would you like to start?
Yeah, so I think, look, it is important to acknowledge that the advocacy space is made even more difficult because of literal harassment and threats of violence, right? So it's one thing to also just be like, advocate, speak up when we know there's a literal threat. I mean, March 10 is Abortion Provider Appreciation Day. because that's the day one of our colleagues was shot and killed because he was an abortion provider. So these are not hypothetical scenarios of us feeling unsafe. And I think part of the advocacy strategies that we should all be thinking about is to what extent do we actually protect the people who then do actually speak up, who do take on that visibility in the work, and how do we ensure that they can do this in a sustainable manner, taking care of their mental health as well, realizing that this is really, really difficult and tough. But I think for me, a movement that I'm really, I can really get behind is to support colleagues with getting the United States as a member state of the UN to actually ratify the right to health, but that would include ratifying the International Covenant on Economic, Social, and Cultural Rights, and that would set the United States on a path to ensure that there is a public health system to speak of in the first place, where you move from the current state where everything is so privatized and around insurance that actually a lot of the dollars that go into different aspects of healthcare can go into one public health service and yield the desired outcomes. And that, of course, would require particular steps, right, that include the lower house of representatives, the Senate. It would include huge amounts of time spent with lawmakers on the Capitol, but also at state level as well. A lot of what that tends to happen in terms of laws and bills and amendments happening is when on the ground there's pressure from those public representatives from their own states, from their own electorate, that they push them in this way. And I think part of the work is that not to wait for the next election cycle before the issue of abortion and women's rights make it into the conversation around who will be the next president, in that we need to work in between all of that to ensure that finally, what I think will be ultimately that the US itself should be held accountable before human rights bodies. And that is a good thing, right? It is a good thing to be held accountable. It is a good thing as a member state to recognize the right to health as its own independent right. And I think that will set us on a course. And I mean, like I said, I'm happy to support any advocacy at any level to ensure that we move and ensure that even your own representative at the UN, your own ambassador, I mean, the White House is an important stakeholder in this, because we know of the unilateral enforcement of the global gag that affects foreign policy. But you've seen how quickly foreign policy has become domestic policy in the US, right? So how do we meaningfully make sure that we do the domestic work, we do the work of global solidarity, understanding the impact of US foreign policy, but also supporting people on the ground, pushing their own legislations and legislators to do the right thing. And I think from a human rights perspective, from a obligation on the part of the state, from an international law part of the state, I think it's important to push the United States to ratify once and for all the International Covenant on Economic and Social and Cultural Rights. And that will set us on a path for a right to health to be recognized, but for a public health system that will be supported, I think, intentionally with all of these dollars to yield the right results.
So maybe to build on that really important point, I think, as Dr. T shared, the US hasn't signed and ratified all that it could. And there's a lot of cynicism about the use of human rights here in the US because our courts, especially our Supreme Court, doesn't always seem to care, doesn't really take a lot of credence, in these obligations. And yet, I think what we know and what we see is that there are really many important roles for human rights, even beyond the citation in a court document, but maybe even to start to say, where abortion decriminalization has happened, looking globally, human rights has almost always played a critical role. That what we've seen, especially in recent years, is that, when that moment comes where the tipping point happens, where we start seeing decriminalization, whether it's in Nepal in 2002, whether it is in Australia now, we are seeing that courts are relying on human rights, they're drawing on human rights principles. And so it is important in terms of the long game to be building the record, because the antis will be anti, but I think when we get to those tipping point moments, human rights has a very important role to play. I think there's also 3 other ways in which international human rights can be used. The first, I think, is to really understand the harms abortion bans are causing in their full breadth, and also to situate abortion bans in terms of the broader attacks on medicine, but also, as Dr. T shared, as forms of structural violence and structural discrimination. And this is something the reproductive justice movement here in the US that was founded and led by Black activists in the 1990s has been so powerful in doing, is really being clear that abortion bans are not really about just abortion, and they are about so much more, that abortion laws, even in and of themselves, are not enough, that there has to be what we call in human rights all positive measures. There have to be positive actions taken to enable access to a right. And so it's not, I think that this is very important. And we saw this in South Korea when you talk to activists from South Korea where there was a great court ruling decriminalizing abortion, that what the activists there were sharing was that it was very important to be building these coalitions to really surface the full breadth of harm that was occurring, and also how this was leading to reproductive oppression. That's like oppression of populations by limiting their reproductive autonomy, both by denying abortion, but also denying access to contraception or causing maternal deaths, that this was also very critical in terms of building public support. So I think that's one really important way. I think another way is to continue to support, is to fight back at the normalization of these abortion bans. And I know from, working in the Philippines for decades and things like that, that when an abortion ban is introduced, it's actually very quick that the ban starts to become normalized, right? This is just how we practice now. And people become scared. And then we start even seeing what we saw in the Philippines, which is patients that are coming in with pregnancy complications being treated poorly, being treated, with stigma and almost like a condemnation. And I think that's something we really need to fight back against. It's important we surface the kinds of harms that are occurring, and that where our highest courts may be failing us, to go to human rights bodies like the UN Human Rights Committee, like the Inter-American Commission, and to outline and to continue to build the record that this is wrong. This is not, this is causing profound harm. We are out of step with every other country in the world almost, and we are really denying our patients here care that pregnant people around the world are receiving. I think that's been really critical. And we saw, for example, in Ireland, how two cases by the International Human Rights Committee, UN Human Rights Committee, were really important, involving 2 different women who were denied abortions and forced to travel for abortions because of Ireland's then very regressive abortion law, was fully instrumental in the eventual decriminalization and recognition of constitutional rights. So I think that's something important to reflect on. And then finally, I just want to flag that it's also important in terms of supporting progressive interpretations. So one thing we've been doing here at PHR, and we wrote a very wonky Texas court brief on it, was about how medical ethics actually require supporting patients' rights. It is a core principle of justice within medical ethical principles. So there's do no harm, right? There's acting with beneficence in the interest of your patient, but there's also serving justice. And there's some really important statements by the AMA and ACOG and others really talking about this justice principle. And so really recognizing that through this lens of linking ethics, medical ethics and human rights, it's also a way to do advocacy within our own communities about why it is we are mandated to act ethically to provide care, to not deny care, to support our patients in accessing information. And I think there was a great question in the chat about what can institutions do? What can clinicians do? It's very difficult, and that's a fact. But there are these ways that if we can frame these, the links between ethical issues and standards of care, it can provide some openings to think about, other ways to advocate for more liberal interpretations.
Great. Dr. Belmonte or Dr. Ortiz, go ahead.
Yes, thank you. I just want to highlight the human rights, but mostly the right to health could be one of the things, but to work, but not just the physical health that is common to see that are going about physical. It's about mental health, which was something that worked in Argentina, at least, giving this big approach to the health, including mental health. The results of the mental health for those women who didn't have an abortion. And there's some data, at least in El Salvador and in Guatemala, 24 cases of young women, all of them poor, unwanted pregnancy, and who suffer from gender violence from mostly by their partners. 24 of them, of these cases, committed suicide during pregnancy. And the stories of these women are very sad. All of them were looking for terminate the pregnancy, but they couldn't, and they were cornered to commit suicide. And there's some data here in the U.S. about that, about suicide during pregnancy, and not just during the pregnancy, but after pregnancy. If we expand to 1 year after pregnancy, the data shows that some women that have been forced to deliver unwanted pregnancy, most of them coming from violence, are committing suicide. And if we gather all the data, could be the leading cause of maternal mortality or mortality related to the pregnancy, by far more than preeclampsia, hemorrhage, sepsis. So it's just about showing those data. And it would be very interesting if we can show the results of the mental health of those women who didn't have abortion.
Great. Dr. Belmonte, did you want to weigh in on this question at all?
No, but thank you all for your points. I echo all of that. I think we really need to be thinking about this issue from all angles to really understand how we can affect the best change.
Thank you. Well, we're getting to our last minute, so I'm fearful of opening the door to another question, and would rather be respectful of everyone's time and really just thank everyone who made today's webinar possible. Physicians for Human Rights, Physicians for Reproductive Health, Ipas, the Global Health Institute, and all of my colleagues at the O'Neill Institute who have been working hard behind the scenes. And we're so grateful to all of our distinguished speakers who have shared their expertise. This is an incredibly timely conversation. There are a lot of threads to pull at further, certainly, in how the US can continue to learn from the experiences of other countries, to look towards the international human rights standards that do really align with medical ethical principles, and how we can continue to support providers in this country, as well as the patients that they serve in this new legal context. So with that, thanks again to everyone, as well as to all the participants for their participation. And I hope everyone has a good rest of their day. Thank you all.